Hey guys, we're going to get started with Megan Eguchi presenting for the Public Health Shared Resource. You are in the right spot for Dr. Ewald's talk. So just stay tuned for that, but for now, just enjoy a 5-minute quick presentation of the Population Health Shared Resource. Thanks.
Okay. Hi, I'm Megan Eguchi, and I'm the manager of the Population Health Shared Resource. Cathy Bradley and Myles Cockburn are our co-directors, and as Jill mentioned, I'm just going to take 5 minutes to tell you guys what we do in case you might want to use our services. So our main services are focused on population-based data, which kind of distinguishes us from biostatistics. But we mainly help with pre-award services if you need study design consultation, preliminary data, study feasibility for population-based studies. We help out with database research activities, constructing analytic data sets. We do some survey database development, again with population-based databases. Geospatial analysis will help you map your population-based data sets. And then one thing that we've been working on developing is our field research and health disparities projects. We've hired someone who can help with minority recruitment, engage with community partners, and also provide Spanish translation services. So this is just to give you an idea of the data and resources that the PHSR has already invested in or we have experience in, and to give you an idea of the population-based data sets that we work with. So cancer registry data, we have the Colorado Central Cancer Registry, and then we work a lot with SEER data, which is about 30% of the national cancer cases. And then in blue are the ones that we have established, gray are the ones we're in progress working on. Another big data source that we use is health insurance claims. One is SEER Medicare, which is SEER cases linked to Medicare claims. And then another one I want to point out is the Colorado All-Payer Claims Database, which we've just been starting to work with. We'll also help out with survey data, some of the census-based surveys, and then behavioral risk factor surveillance system. You can see the different software that we use, and then one thing I want to point out are our sites and partners that we've been working on recruitment and community-based projects with. Of course, here at UC Health, Latino Research Policy Center, we have some projects with the Mexican Consulate, and then local schools and clinics. So I just wanted to choose a few examples of projects that we've done so you can see the kinds of data sources we use and what they can be used for. So this first one is a catchment area assessment, and you can see it's the rural residency overlapped with ethnicity for Hispanic colorectal cancer cases, and the darker purple indicates higher proportions of the CRC cases are Hispanic, and then the kind of hashed areas are the urban centers. So one thing we saw was that Hispanic CRC cases tend to be located away from urban centers. So you can see that this might be useful in a grant proposal, providing an assessment of the catchment area, or if you need to target your intervention services, the cancer registry data is a good source for that. Another area we've been doing a lot of work on is SEER Medicare research. And then, as I mentioned, SEER Medicare is the SEER registry linked to Medicare claims data. And one collaboration that we've had with head and neck cancer has been ongoing and productive. Dr. Bradley and Dr. Karam in head and neck cancer provide mentoring to fellows and junior investigators. And we've used the SEER Medicare results for things like grant support. And then I think we're up to 6 publications now with the SEER Medicare data. And we looked at different things like survival, chemotherapy, survival outcomes, concomitant medication use, imaging at diagnosis, and tumor characteristics. So all those things you can get through SEER Medicare. And then the last project I want to touch on was a recruitment project, looking for underserved patients, recruiting them for mental health services, and that's a PCORI trial. Jose Barron is our outreach and recruitment coordinator, and some of the activities he's done for that project so far are screening patients for study participation, recruiting them at the UC Health clinics, and he'll conduct surveys and obtain consent in both English and Spanish. And then he helps out with the project coordination stuff, things like PRMS and COMERB applications and encore management. So that should just give you an idea of the services that we provide. We provide an initial consultation and exploratory analysis for free, and then we have an hourly rate if you want to continue. But if you're interested in any of those things, you can contact Dr. Cockburn or myself, or visit our website, medschool.ucdenver.edu, Cancer Center Population Health. And that's it. Yep. Let's just close that.
Okay. Hi.
Good afternoon, everybody. I'm Dan Pollier from the Division of Hematology. It's my great pleasure to introduce and welcome Mark Ewalt this afternoon for his seminar. Mark is relatively new to our institution. He did his medical school and residency training at Columbia University in New York. He then went to Stanford for a hematopathology fellowship, as well as a molecular pathology fellowship, and we recruited him here just a few years ago, and we have been the beneficiary of Mark's expertise and interest in this area. He's a real leader in the area of molecular diagnostics for myeloid malignancies, and has quickly partnered with our group on the clinical side to improve the diagnostic, prognostic abilities to help with patient care using molecular pathology. He has a very fascinating research interest, and we're really excited to hear what he has to say today. So please help me welcome Dr. Ewalt.
Thank you, Dan, and thanks everyone for coming out today. I am going to talk to you about a topic that's been becoming increasingly interesting and realized in the field of malignant hematology in the last few years. And it's these inherited hematopoietic malignancy risk syndromes or mutations. Just to start, I have nothing to disclose. And over the course of the talk, I hope that you'll come away understanding a little bit more about the different patterns of presentation in patients who have inherited risk of a blood cancer, that you'll be able to at least understand a few of the specific subtypes of inherited blood cancer. There's a very long list, as you'll see shortly. And then I also want to propose a way to incorporate this understanding into routine treatment or screening of all patients who come to you with blood cancers. So when we think about some of the clinical characteristics of patients who have an inherited risk of a blood cancer, there's a lot of overlap. Many of these patients will present with a cytopenia either in childhood or adulthood. Some patients will present very early with a constellation of symptoms, including physical abnormalities, endocrine dysfunction. Some patients may be completely normal until later in life, or they may come to you with a very strong risk of a solid tumor or multiple different types of cancer, either in a personal history or family history. And all of these features overlap, so it can be a little bit complicated in trying to figure out what's the best way to categorize these and what's the best way to think about these. So recently the WHO has started to recognize these as distinct entities and has sort of broken them into three different groups. So the first group is the group associated with platelet dysfunction. The second group is that which is basically patients who are normal. And then the third is patients who have some other organ dysfunction. And as you can imagine, that's going to be a pretty long list. And in expanding this, it's not quite as simple as just three groups. There are a few that are associated with platelet dysfunction, a few that are pretty much isolated hematologic cancer risk, but then there are a variety of genes that are mutated in patients who have other syndromes. And just kind of looking at bone marrow failure syndromes, we have the Fanconi anemia genes and DNA repair. We have Shwachman-Diamond syndrome, GATA2 or Monomax syndrome. We have the Mirage syndrome and ataxia pancytopenia we'll talk about later, as well as bone marrow failure syndromes. There are those that are associated with mutations in telomere biology. Mostly these are the dyskeratosis congenita mutations, and there's a long list which continues to grow. And then there's also those associated with Diamond-Blackfan anemia and a few others like Noonan syndrome and severe congenital neutropenia. So overall, this is a pretty extensive list of genes that can be mutated and be associated with an inherited risk of hematologic cancer. I hope that you guys brought pillows because we're going to go through each one of these now in alphabetical order. So one of the questions you may be wondering is, okay, this is a little bit overwhelming. You showed me a giant list. When do I start to worry about inherited risk? Do I need to think about it in every patient? Should I only worry about it in kids? And really, there are a few things that should really tip you off. It's good to have an idea that this is more common than we used to think and to consider it in all of your patients. But strong personal and family history is key. So whenever you see a new patient with a hematologic malignancy, you want to understand, do they have a history of bleeding or bruising? That may indicate a platelet dysfunction. Or is there a family history of that? Maybe there's a strong family or personal history of a hematologic cancer, and that may make you think of something like a DDX41 mutation. Or you may hear about a very strong family history of something like breast and ovarian cancer. The BRCA genes are actually part of the Fanconi anemia genes. And so you may not hear about hematologic cancer per se, but you may hear about other types of cancer. So you want to kind of keep an open mind and a high index of suspicion. And lastly, now that we're starting to do broad-based next-generation sequencing testing on most of our patients at diagnosis, we may find something very suspicious on our next-generation sequencing testing. We tend to now sequence about 40 to 50 or 60 genes on most patients who come in with a myeloid neoplasm. And so we may find a mutation that we think of as mostly a germline-associated disease mutation, or we may find multiple mutations. We'll look at that a little bit more later on one of the cases, but really those findings can be very, very provocative. And why does this matter in clinical care? It's really important for both the patient and their family for understanding their relapse risk. Some cancers, they will have multiple relapses. We'll look at a case of that later. Also to understand surveillance for additional types of cancer. Many patients are going to have numerous types of cancer, whereas patients with a germline CBP alpha mutation are going to generally just have recurrences of AML. It's going to be important for understanding the therapy for those patients. We know that Fanconi anemia patients have a very poor response to alkylating agent therapy, and so you want to avoid that and go with different types of induction therapy for those patients. Also, when we think about hematologic cancers, many of these are cured with stem cell transplant, and if you have an inherited disease, you probably don't want to go with a related donor unless you've done extensive testing to ensure that your related donor doesn't carry the same mutation that drove your patient's initial cancer. And lastly, it's very, very important for the family. It helps them understand who needs to be screened for the mutation and potentially for additional cancer screening. And also it may be helpful in family planning. Now, we can offer patients the option of in vitro fertilization and pre-implantation genetic diagnosis so that they can select an embryo that will not have the same mutation that they carry. So because that list is obscenely long, and I don't want to kill all of you, I wanted to present these as a few clinical cases to illustrate some of the points that I think are important when thinking about inherited hematologic cancer. So our first case is a 3-year-old girl. She was born very small, and at an early age, she was noted to have adrenal insufficiency. She had multiple recurrent infections over the course of her life up to age 3, and she presented with cytopenias and was found to have circulating blasts in the peripheral blood. A bone marrow biopsy then showed dysplasia, and she was diagnosed with myelodysplastic syndrome. Part of routine workup in MDS is to get a karyotype. This patient had monosomy 7 and trisomy 21. I'm showing you here also the patient had a RACGH. This is a copy number plot where 0 means normal copy number. You can see that there's loss of signal in chromosome 7. And chromosome 21 is an itty-bitty one, but you can see that there's a gain of signal up at chromosome 21. And because the patient was so young and had myelodysplastic syndrome, they wanted to do a broad screen, so they did whole exome sequencing on her peripheral blood, and they found no mutations. So they got a little bit more history, and the patient's older brother was also small for gestational age and also had adrenal insufficiency. He had had some genital abnormalities with hypospadias and scrotal malformation, and he had also had a cytopenia in the form of thrombocytopenia. So here's a pedigree. Both parents were healthy and normal, but both children were affected. So the astute clinician who was taking care of this girl said, your brother sounds like he might have this Mirage syndrome. So Mirage here, it stands for myelodysplasia, infection, restriction of growth, adrenal hypoplasia, genital phenotypes, and enteropathy. This is a syndrome that's caused by germline mutations in the gene SAMD9. There's another closely related syndrome caused by mutations in SAMD9L. This is an ataxia and pancytopenia syndrome. SAMD9 and SAMD9L both work downstream of EGFR signaling, and normally they dampen growth a little bit. However, in Mirage and ataxia pancytopenia, it's felt that an inherited mutation is a gain-of-function mutation that causes growth restriction, it causes the hypoplasia, it causes the cytopenia. And so that's what causes these phenotypes in the syndromes. So the brother was sequenced and was found to have a SAMD9 mutation, as shown here. But as I said, our patient was negative. So they took that same DNA that they had sent for whole exome, they did sequencing just for SAMD9, and it was still negative. So why was her whole exome normal? This is strange. Well, so it has to do with the patient's monosomy 7. So the thought is that this gain of function in SAMD9 and SAMD9L causes impaired growth of various different things, including the adrenals, including the bone marrow cells. This leads to a cytopenia. And in the setting of a stressor, the patient needs to respond. For example, in the setting of these recurrent infections these patients have, they'll have interferon stimulation, and that these stressors will induce some other genetic event. So here are 3 different mechanisms shown. One, you have loss of the wild type allele with non-homologous recombination, and you end up with uniparental disomy. So you basically lose the mutated allele and just duplicate the normal allele from the other copy. You can add another mutation, which is a loss of function mutation, to compensate. So basically, if it's in the same allele that was hyperproductive, if it acquires a secondary mutation that knocks it out, then that will take care of the hyperactivation of SAMD9 or SAMD9L. Or as common in these patients when they develop a myeloid neoplasm, they have monosomy. So they lose the entire chromosome 7, which is where SAMD9 and SAMD9L are located. This restores a relatively normal growth rate from the perspective of the SAMD9 signaling. However, there's a lot of material on chromosome 7. As you saw from the array, it's a fairly long chunk of signal. And it's thought that the loss of the other genes that are present on chromosome 7 is what leads to the myeloid neoplasm seen in these patients. And so this is what we think is happening in our patient. And in fact, they did a skin biopsy. They cultured fibroblasts, and then they sequenced that, and they found an identical SAMD9 mutation to that seen in our patient's brother. So this is a myeloid neoplasm with SAMD9 or SAMD9L mutation, and these are usually seen with some kind of multi-organ syndrome. So if you see a patient with multi-organ syndromes, this is something that would be part of your differential. Obviously, we aren't going to go into all of the different syndromes and all of the different phenotypes, but depending on the specific phenotype of the patient in front of you, it may prompt you to think about certain syndromes higher than others. As I said, the SAMD9 mutations are associated with Mirage, and SAMD9L are associated with the ataxia pancytopenia. These patients will frequently have monosomy 7, and so when you do sequencing on somatic tissue, in this case we took blood from a patient who had MDS, you won't be able to detect the mutant allele. So it's important to do germline sequencing in these patients. Our second case is a 12-year-old boy who presented with AML. And his family history is notable for intermittent thrombocytopenia. Morphologically, he was pretty normal, no physical findings. And his family history is notable for many relatives on both sides of his family, male and female, who have breast cancer. So one of the things in med school, when you're thinking about familial breast cancer, when you think about male breast cancer, often BRCA2 is implicated in male breast cancer. So that should sort of make you perk up a little. And one of his aunts had screening with one of these cancer susceptibility profiles. And she was told that she had a mutation in, quote, one of those breast cancer genes. So again, just given this clinical history, we're thinking maybe this patient has a BRCA2 mutation. It's a little weird that he's presenting with AML if he only has one mutation. So he was sequenced, and he was found to be a compound heterozygote. So he had two mutations on opposite alleles. Both of these are pathogenic mutations. The first one is a splice site alteration, and the second one is a frame shift that leads to a stop gain. And so both are non-functional BRCA2. So how does this cause the patient's phenotype or his AML? As I mentioned earlier, BRCA2 is one of a long list of Fanconi anemia genes. So it accounts for about 2 to 3% of cases of Fanconi anemia. It was investigated separately as a breast cancer susceptibility gene and was separately called FANCD1 because it was a Fanconi gene as well. And then they realized probably 10, 12 years ago that these are in fact the same gene. And Fanconi anemia can have a lot of different phenotypes. So patients may have developmental delay. They may have physical findings, including facial abnormalities, cardiac abnormalities. Classically, they'll have radial abnormalities and thumb hypoplasia. This patient, I said, had no physical abnormalities, but up to 40% of patients in some series may have minimal physical findings. So although this is unusual, it is possible to have a patient who looks normal and only has a cytopenia and has Fanconi anemia. So, as I mentioned early, Fanconi is a disease of DNA repair. So there is a huge number of genes that are associated with Fanconi's, and each one of them codes for a different component of a DNA repair complex. And they're called they call them complementation groups. So if you threw in a known gene of the same complementation group, you could rescue the phenotype caused by it. But these patients all have impaired DNA repair, and because of that, when they get hit with an alkylating agent or traditional chemotherapy, they have massive chromosome damage. This is a picture of sort of the diagnostic assay for Fanconi anemia, and in this case, they take the patient's cells, they culture them, and then they treat them with diapoxybutane, and they look for the presence of numerous chromosome breaks, and then also they say quadraradials and triradial forms. So they have very, very abnormal chromosomes after getting treated with alkylating agents, and this is because of the failure of the DNA repair response. So in our patient, this 12-year-old with AML, they cultured some of his cells, and in fact, he did have increased chromosome breaks on the DEB assay, which is diagnostic for Fanconi. So as I said, this is often seen with physical abnormalities, and this one is associated with increased cancer risk. About 30% you have a 30% chance of having a solid tumor, or 10% chance of hematologic malignancy, but by, I think, age 30. So these patients have a very high cancer risk, and it's both solid tumors and hematologic cancers. Depending on the specific mutation that the patient carries, they may have different organs that are impacted. BRCA mutations are associated, obviously, with breast and ovarian cancer syndromes, as well as brain tumors, and AML is seen in this case. And these patients don't respond well to alkylating agents. There tend to be a lot of adverse events, so it's important to recognize these patients for therapy planning. And molecularly, as I said, there's a lot of causative genes, and most of them are autosomal recessive, so you may not have a very strong family history of Fanconi anemia, but you may have a strong family cancer history, as you did in this case. So that should be your tip-off that there might be something going on, particularly in a young patient, as seen here. The next one is a case actually taken from a paper that Dan was an author on. This is a 67-year-old man who presented with MDS and excess blasts. So you're probably wondering, he's 67. This is an inherited disease talk. Most MDS patients present kind of in middle age, maybe their 60s, maybe their 70s. He had a karyotype done, which was normal, and had whole exome sequencing. and they identified multiple mutations. 2 mutations in DDX41, which is a dead box RNA helicase, a mutation in CDH26, and a mutation in TP53, which is our old friend. So one of the most mutated genes in cancer. They then dug a little bit deeper into the NGS data, and they actually looked at the variant allele frequency seen in these patients. So variant allele fraction, or VAF, is the percentage of the DNA reads that correspond to a particular signal, either wild type or mutant. So here I'm giving you the percentage of reads that came from the mutant read. And you can see that this frameshift DDX41 mutation was present in 50% of reads, so it looks like it's heterozygous. You have to be careful with these because sometimes looks can be deceiving. We know that cancer tends to have a lot of aneuploidies, so gains and losses of chromosomes, and so you can have that conflated by the aneuploidy. So if you have loss of heterozygosity, as often happens in P53, you may have an inflated VAF because the mutant copy hangs around, whereas the wild type is lost. Or as we even saw in the last case, or prior case with SAMD9, you can have a drop in the VAF if you end up losing the mutant copy. So you have to be a little careful in interpreting VAF. But this looks like there probably was a founder clone or an early clone that had this DDX41 frameshift, and then there were sequential subclones that evolved with additional mutations, as shown here, with eventually a secondary DDX41 mutation. So is this useful from somatic testing? So I just gave you a couple of caveats on it, and so you may be wondering, really, is it worth chasing this down? And so actually the University of Chicago group did a study looking at this, and they wanted to say, is this useful? And they looked at 360 patients who had had somatic tumor-only sequencing, and they looked then to see which ones had mutations in hereditary hematologic malignancy-associated genes, and they shrunk that down to about 20% of the initial cohort. And then they wanted to see, did they have germline tissue available so that they could see, is this an actual germline mutation, or are we just looking at something with a specific VAF? And they ended up with 44 patients who had 52 variants that were classified as either pathogenic or likely pathogenic. So the mutations that generally should be reported and that you would be following up on and concerned about clinically. And when they look at this, they then split them into the ones with a variant allele fraction of greater than 40% in tumor or less than 40% in tumor. And what they found was that almost a quarter of those pathogenic mutations that were present at a VAF of greater than 40% turned out to be germline. So that's a pretty high percentage of your high VAF mutations. And so really this should perk you up. And then if it was a VAF of less than 40%, none of them were germline. So this suggests that using a VAF threshold of 40% is a pretty good cut point for when you should consider a germline mutation, at least when you're doing somatic sequencing. It's not going to be the be-all and end-all. It won't be entirely confirmatory. As we saw with the SAMD9 case, you may miss some things. But definitely it may be a trigger to consider additional sequencing. And they found that there is some variability in terms of which genes tend to have a high VAF and be associated with a germline mutation. So all of the DDX41 mutations that were looked at in this cohort that had a high VAF turned out to be germline, whereas at the other end, the P53 mutations, even in patients with suspected Li-Fraumeni with a high VAF, tended to not be germline. They were somatic variants. And you may be wondering, well, why is that? I mentioned P53 is notorious for having LOH, or loss of heterozygosity. So the normal copy is lost, and you end up with hemizygosity for a non-functional mutant allele. And that can inflate your variant allele fraction when you're looking at it in tumor samples. So they got a little more history in this case as well. And this patient had a brother who died at 58 of AML. And they did germline sequencing on him, and they found that frameshift DDX41 mutation was present in the skin biopsy, and the secondary DDX41 mutation was a somatic mutation in that patient. So that one with a high VAF, 50%, turned out to be germline. DDX41 mutations are not very common overall, but when they occur in families, you tend to see an increased number of patients in the family with a hematologic cancer. So this is just a a sample of some of the pedigrees shown in this study, again from the University of Chicago group, and they found that many of these families ended up having multiple people across different generations who have this blue line, meaning they had some hematologic cancer, usually MDS and AML. Also, these mutations tend to be associated with higher risk disease. So compared to wild type DDX41 patients, they tend to have higher risk MDS, and they tend to have more primary acute myeloid leukemia. So these patients present with high-grade myeloid neoplasms, not a low-grade MDS. And also these patients have a lower overall survival. So this is something that maybe the patients present at the same age as patients with MDS or AML, but they present with a high-grade disease, and they have a poor prognosis. This is again from that paper that Dan was part of. They found that in this small study that there seemed to be some correlation with the DDX41 mutation and response to lenalidomide therapy, but as far as I know, this has not been replicated yet. So this is certainly provocative, and it could offer a therapeutic option in these patients. Interestingly, in terms of the mutation spectrum in this gene, most of the germline variants tend to be clustering kind of at the N-terminus, and they tend to be frameshift mutations leading to early termination, and they're thought to be non-functional, whereas many of the somatic or acquired mutations are closer to the C-terminus, and in biochemical studies, these lead to a hypofunctional protein. So overall, it seems to be loss of the function of DDX41, and looking at some of the basic science studies, DDX41 tends to associate with the RNA spliceosome. It's an RNA helicase. It associates with the spliceosome, and mutations in DDX41 are mutually exclusive with those seen in other spliceosome components. So there's a thought that this may be involved in RNA splicing, and RNA splicing is a recurrently altered pathway seen in a lot of myeloid neoplasia. It hasn't been completely elucidated how this functions or how aberrant splicing impacts myeloid neoplasm. So still many open questions about the function of this gene. But in summary, clinically, the myeloid neoplasms with DDX41 tend to occur in older patients, so patients who may not be thinking about having a germline predisposition, but they present with high-stage disease, they do pretty poorly, and they may respond to lenalidomide, according to a small study. But molecularly, the germline mutations tend to be N-terminal loss of function, and the somatics are generally hypomorphic C-terminal mutations. So our next case is a 39-year-old woman who presented with AML. She also had a normal karyotype, and let's say she was tested 10 years ago before NGS testing was widespread. So at that time, we were doing single gene testing for certain genes that were associated with prognosis in AML. These tended to be things like FLT3, NPM1, CBP alpha. She was found to have two mutations in CBP alpha, one closer to the N-terminus, one closer to the C-terminus. And she was wild type for FLT3 and NPM1. So at this time, she was diagnosed with AML with biallelic CBP alpha mutation. This is a good prognostic subgroup of AML, and so things seemed good for her. But then she relapsed 7 years later. So she got chemotherapy, she responded. 7 years later, she relapsed. And at this point, we're in the age of NGS. We're after the 2016 WHO. And so they introduced a new entity called AML with germline CBP alpha mutation. So her astute oncologist noted that she again had biallelic CBP alpha mutations, one of which was the same as seen in her initial AML, this first one, whereas the C-terminal mutation now has changed. She also has an acquired GATA2 mutation. And because of this, the oncologist decided to do germline sequencing, and so got a skin biopsy. This showed the same CBP alpha mutation that was present in both of the patient's leukemias. And so this patient was re-diagnosed as AML with germline CEBP alpha mutation. So here are a number of additional pedigrees of patients with germline CBP alpha mutation. And here you can see a clearly autosomal dominant, very penetrant pattern of inheritance. There are patients in pretty much every generation of every pedigree who have AML. So this is a very penetrant disease. And generally the germline mutations cluster in the C-terminus of the protein. So CBP alpha is a transcription factor, but the gene has two different start sites. So it can transcribe a long RNA or a short, it can translate either a long or a short protein, the P42, which is the long isoform, or the P30, which is the short isoform. When you have the germline mutation, you lose your long isoforms. You're restricted to just P30, and then acquired mutations tend to cluster in the C terminus and alter the function of the P30 isoform. This is the same pattern of mutation that is found in patients who have sporadic double mutant CEBP alpha. As in our case, where we saw a change in the second CBP alpha mutations, it's very common that patients who relapse with inherited CBP alpha mutations will have a change in their second mutation. So that first AML that they have is completely cured by chemotherapy, and it's a second de novo AML that occurs. So clinically it looks like a relapse, but in fact it's de novo disease arising from the same altered stem clone. And just showing you kind of these fish diagrams, which show you various clones. Say you have an initial patient who has this germline pool. Every cell here has a germline CBP alpha mutation. One of these cells will go on to acquire secondary CBP alpha mutations and additional hits, and this will clinically present as acute myeloid leukemia. These are very sensitive to chemotherapy, so this patient is going to achieve a cure and clear the clone out here. But unfortunately, subsequently, another one of the clones that was hanging out here is going to arise with additional mutations, eventually a second CBP alpha mutation, just like this one did, and you're going to present with another AML with two CBP alpha mutations. And these patients tend to recur multiply. They'll get treated, and then they'll relapse, and then they'll get treated, and they'll relapse, and these patients can relapse 2, 3, 4 times. Despite all of that, they have a pretty good overall survival, which is interesting, but also it's the silver lining, I guess, on this story. So if we look at all of the patients who come in with a CBP alpha mutation, patients who have an inherited CBP alpha mutation have the best overall survival compared to patients who have a sporadic biallelic mutation. And as I said earlier, that's considered a good prognostic subgroup. Those patients do better still than patients who just have a single CBP alpha mutation, which is thought to sort of be a passenger mutation rather than the disease driver. Interestingly, when you look at young patients, though, who are under 45, they found that the curves collapse for the familial and the spontaneous double mutant cases. And this is pretty interesting because it makes you wonder how many of those patients actually really are patients with germline CBP alpha. And some of these large studies looking at several hundred patients with AML, they have found that approximately 10% of patients who have what we call sporadic double mutant or biallelic CBP alpha mutation actually have a germline CBP alpha mutation and really should be reclassified and monitored differently as well as their families. So clinically for AMLs with germline CBP alpha, they tend to present much earlier than normal patients with AML. And this is a nearly 100% penetrant syndrome. So you will see many, many patients in these families who have an AML. And they tend to have a pretty good response to chemotherapy, although they will have multiple relapses throughout the course of their disease. Molecularly, most of the germline mutations occur in the N-terminus, and the novel mutations or the somatic mutations that these patients get are in the C-terminus, and every relapse is going to have its own unique mutation. And lastly, it's good to remember this because about 10% of patients who have a biallelic CBP alpha mutation actually have a germline mutation as their underlying alteration. So I want you to remember as you go through this that inherited risk of hematologic cancer isn't really as rare as we used to think it was. We used to think, okay, maybe it was in those kids with Fanconi anemia or in patients who have other syndromic diseases, but there are a lot of patients who have no other symptoms of a hematologic risk disposition, and they actually are carrying one and their families are also at risk. As we continue to do expanded testing on patients for somatic disease, we're going to continue to see additional inherited risk factors that pop up. And it's critical to accurately identify these patients to be able to manage them. It would be tragic to transplant a patient with stem cells from a family member who has one of these germline mutations and then see them present shortly thereafter with a donor-derived leukemia because we missed something that was in their family member who then was their donor. So I'd like to propose an approach to all of our hematologic cancer patients moving forward. So I think the first thing is we have to consider germline risk in all of our patients, so everyone who comes in. There definitely are some features that should make us stop and think. Multi-organ syndromes, so patients who have Fanconi, who have Noonan syndrome, those are patients who you should definitely think about screening and trying to identify their underlying genetic alteration and then see if it's associated with hematologic malignancies. Next, a personal or family history of cytopenia. Some patients may only present with thrombocytopenia or a transient cytopenia with really no explanation, and these patients should be followed, and if they do later present with a neoplasm, a germline predisposition syndrome should be suspected. Also, patients who have any type of cancer. So it's better to not think of cancer as a specific disease of a particular organ, but it's a disease of the genome. And so when we have inherited risk factors, we have inherited risk to all cancers. There may be some predisposition to the particular organ, but it's important to think about it more broadly. Next, as we saw from the Chicago group, when you have somatic testing done and you have a very high variant allele fraction, this should give you pause and make you say, is this a gene associated with germline risk? And if so, maybe I should consider doing germline testing in this patient. And then also biallelic mutations. So both CBP alpha and DDX41 are associated with biallelic mutations on somatic testing. So that should be another clue to consider germline testing. Also, non-hematopoietic tissue testing is critical. You can't prove that you have a germline mutation without germline tissue or without a related family member to test. Generally, cultured fibroblasts are considered the gold standard, but this takes 4 to 6 weeks to acquire, to culture, to extract nucleic acid. And a lot of laboratories are looking at other methods. Children's is using fingernails. Over in Komoko, where I work, we're looking to also start working with fingernail DNA. And other labs will use hair follicles. That's probably not going to be as easy to acquire. A lot of patients don't like to have their hair pulled. Some patients are like me, and you're not going to get much. So generally, I think fingernails are becoming more common. Buccal swabs are notoriously poor sources because there tends to be a lot of infiltration by monocytic cells, and monocytes derive from a myeloid lineage. And so if we're looking for myeloid neoplasms, then it's not going to be helpful, and we may see the same somatic mutations. And lastly, involved genetic counseling. So these are patients who have a risk and their family has risk. And it's important to involve some experts who can help give that counseling and recommend appropriate testing and follow-up for patients and their families. So at this point, I'd like to say thank you very much and ask if anyone has any questions. Yes. The question is, what is lenalidomide and why should it be so effective in DDX41 mutations? So I'm going to look to Dan a little bit for help with this. My understanding is that lenalidomide is an IMiD. It's a thalidomide analog. It has immunomodulatory properties. It's not entirely clear what its mechanism of action is, but it tends to be effective in some subtypes of MDS and other myeloid neoplasms, and tends to have a different toxicity profile to traditional alkylating agents. Is that generally?
That's great. The only thing I would add is that lenalidomide has this unique activity in a subset of MDS patients that have deletion of 5q. And it's actually getting fairly well understood how it works, and it has to do with these casein kinases that get ubiquitinated by the lenalidomide. But what's really intriguing about this is that the DDX41 is on that commonly deleted region of 5q. And so I think that's a very tantalizing clue about what its mechanism is or why it can be so effective in DDX41 patients, but I really don't know the mechanism. I don't think the mechanism beyond that is known.
Yes.
So in your first case, you mentioned
Yes.
So are those mutations gain-of-function mutations?
So the question was, are the SAMD9 mutations seen in the first case gain of function? And yes, so it's a little confusing, but SAMD9 and SAMD9L are proteins that normally attenuate or inhibit growth of cells. The thought is that in the inherited syndromes, patients have a gain of function, so they have even more inhibition of growth than should normally be provided by SAMD9 or SAMD9L. And this is what leads to the impaired growth, so small for gestational age, to the cytopenias, to the adrenal hypoplasia, and to some of the other physical findings that are found in these patients. And then the thought is that the reason they develop a neoplasm is that when they're under stress and they need to try to overcome this growth restriction imposed by those gain-of-function mutations, there are different mechanisms that happen, and one of those is loss of the entirety of chromosome 7. And when that happens, it takes critical genes that are required for normal hematopoiesis away, and that's what leads to the MDS. So it's really just the genome trying to fix this pathogenic gain of function to get a normal level of functioning that gets a little overzealous and kicks out the whole chromosome, and that's what causes the MDS, not actually the SAMD9 causing the MDS. So I tried to pull cases from literature wherever possible because I don't want to start making up cases and be horribly wrong on these. In this case, the parents were not sequenced. There are other cases where they have sequenced parents, and they've found that sometimes the parents will have the pathogenic mutation seen in the children, but in addition, they'll have a loss of function mutation in cis. So back on that diagram, there were kind of 3 mechanisms that were put out in that cartoon for ways that the genome can compensate. The first is through UPD, so you lose part of the chromosome and you replicate the normal copy of SAMD9 or SAMD9L. The second mechanism was acquisition of a loss of function mutation in cis or on the same copy that had gain of function to sort of bring you back closer to normal level of functioning. And then the third was the monosomy. So at least in some cohorts, the parents who do have these mutations will have a compensatory loss of function mutation that for whatever reason is not transmitted either from just copying error during gametogenesis or through crossing over or bad luck. Any other questions? Yes?
When you're categorizing the inherited risks, one category that occurs
Mm-hmm.
in other hematologic clues, the common one is macrocytosis. Family history of macrocytosis, screen the donor.
Right. I think there are definitely macrocytosis is often seen in patients. The question, I'm sorry, was when we're looking at inherited risk and patients who should be screened, we talk about cytopenia, particularly thrombocytopenia, and the question was raised, should we look at patients with macrocytosis? And yes, we know that there is macrocytosis in a lot of patients who have different kinds of hematologic cancer. It's seen in a lot of myeloid neoplasms. Classically, MDS, you'll have a macrocytic anemia as one of the first symptoms. But I think because macrocytosis is also common related to other things, it can be challenging to screen everyone with it, but I think it's definitely a good clue. So I think really any abnormality on the CBC that's persistent and can't otherwise be explained is important to consider following up. So in terms of screening siblings of patients or?
Donors,
Mm-hmm.
potential donors,
Yes.
and all 3 brothers carry macrocytosis.
Yes. I think it's reasonable, but I would say if you have someone who definitively has a germline syndrome, it would be easier to just go straight for the alteration. I'm not sure I'm totally getting your question, but we can chat after maybe. I apologize. Are there other questions? All right, thank you very much.